Good afternoon, everybody. My name is Ashish John. I'm the Dean of the School of Public Health here at Brown and Professor of Health Services Policy and Practice. Welcome back to our monthly series of conversations with distinguished global public health leaders. And today, the conversation is going to be with Dr. James Gavin III, and I will introduce Dr. Gavin in a second. Before we get started, I just want to remind everyone today's event is being recorded and will be shared later on our websites. Please feel free to submit your questions. You can put them into the Q&A box at any time, and my goal is to try to get it to as many of them as possible. I'm going to start the conversation with just my asking Dr. Gavin a series of questions initially, and then we will turn to the audience for Q&A. Now, speaking earlier with a colleague this morning about this event that we're having with Dr. Gavin, and we both remarked that if any of us accomplishes quarter of what Dr. Gavin has accomplished already, we would be happy to ride off into the sunset and feel like we've had a distinguished career. He really is a legend of American medicine, has had so many important roles, and I'm not going to list them all because I actually want to have a conversation with him as opposed to just talk about his incredible bio. But he's a physician, he's a PhD, he's was former chief medical officer, served as chief medical officer of Healing Our Village, has been president and CEO of Morehouse School of Medicine, has had a leadership role in the Howard Hughes Medical Institute, which, if you know basic science and know medical science, is really one of our renowned areas of excellence. He has been head of the American Diabetes Association, has done landmark work on diabetes, some of which we will get to, but really has been a leader in thinking about diabetes, thinking about equity in our healthcare system, in our public health, and has won a whole series of awards for his accomplishments. And we're going to get to a bunch of the things as we get into this discussion, but I just want to start off by saying, Dr. Gavin, thank you for taking time and spending some time with us today. Really excited to have you and just thrilled that you could make some time.
Well, it's certainly my pleasure. In fact, it's an honor to join you in this series. And before I go any further, let me first commend you and thank you for doing this, for what it represents to your students and to the people who have partaken of the content of this series, because I'm sure that it has certainly broadened their perspectives. And I want to thank you for giving me this opportunity. And last, thank you for your contributions and commentary during this COVID epidemic. It's really brought credibility and balance, and I thank you very much for that.
Well, thank you. That's very kind. I want to start off by asking you, if you don't mind, just taking a couple of minutes and talking to us a little bit about your career. And what's interesting, there's so many interesting facets of it, but one part maybe we could begin with is a lot of people who are MD PhDs often get their medical degree first and then go on to get a PhD or do it simultaneously. You started off as a PhD scientist and then got an MD. And tell me a little bit about that journey from college to getting your PhD, and then what really made you want to also bring in the medical training and making that a part of your career.
Yeah, it really is a very personal story, and I'll tell you how it happened. I became interested in basic science research in college. In fact, I was the second student at Livingstone College to get a research grant from the North Carolina Academy of Sciences. And I was inspired by a previous Livingstone graduate to go to graduate school, pursue a PhD, which I did in biochemistry, and I developed an interest in doing hormone receptor research, and that's where I started. Once I finished my PhD, I went to the NIH, was working on hormone receptors, which eventually led me from gonadotrophin hormones to insulin, for a number of reasons that I won't go into. But when I started studying insulin receptors, I really didn't know very much about insulin, the hormone, but the study of those receptors led me to a deeper understanding about the disease diabetes, which of course I had no real contact with in my prior training. When I learned about diabetes, I realized that this was the disease that killed my great-grandma. And this was also the disease that affected many of my uncles, and it basically ravished my family. And I made a decision that, you know, if I'm going to spend my life doing research and trying to find insights and truths to improve things, then it makes sense that I probably ought to try to do this in diabetes. But I didn't have the right tools. And to make a long story short, I had to go back to medical school, which I did, to get MD training and then go on from there to do specialty and subspecialty training in endocrinology and diabetes. And the rest, as they say, is history.
So many points I wanted to just pick up there. Tell me more about how you made the connection to realize this was the disease that affected so many of your family members. And how did you connect the work that you were doing in the lab and to that kind of broader population and personal family situation? And I ask it because so often I find that people see basic science as kind of divorced from the reality of people's lives and people's health. And obviously you saw that connection early and it motivated you. Can you talk a little bit more about that?
Yeah, it turns out that at the time that I was learning about diabetes, a great deal of attention was being paid to the long-term complications of diabetes. And of course, one of the big ones was amputation. At that time, amputation, blindness, and heart attacks and kidney failure. And what I recalled as a result of reading that was when I was a small boy, I used to have to travel from Mobile, where I grew up, to Selma, Alabama, which is where my mother's people were from. And we had to spend our obligate amount of time, what we used to call up the country, learning how to farm and do those things. And my great grandmother was absolutely the closest thing to an angel that I ever knew, because she would just dote on us. She baked us sweets. She played games with us. And one summer I was in first grade, and she was bedridden, and she had one of her legs missing. And of course, adults during those times never were forthcoming with children about such things, and we would have to hear the whispers. And one of the whispers that we could hear was something every once in a while that had sugar. And of course, we were confused. How could anything that had to do with sugar possibly do something as bad as this to a person as good as this? And it just made no sense. Well, long and the short of it was that the next year we came back, Mama Rennie had lost her second leg. And then, of course, from that time, we never saw her again because she died in the interim. And I realized that she had dual amputations as a result of her poorly controlled diabetes. And other family members, adults, of course, had other kinds of problems. My Uncle Gus had kidney problems. And it turns out, in retrospect, once I began to understand what this disease could do and how it behaved in minorities in particular, that my family was numbered in that group of disadvantaged, disproportionately affected people. And it became clear that a lot of why that was happening was because we just didn't know how to take good care of this disease, because fundamentally, we didn't understand very much about it. We didn't even know how the hormone interacted at the cellular level to do the things that it had attributed to it. So it was clear to me that we were at a very rudimentary stage of our understanding. And so that was the connection that I made. I wanted to get in on that, understand what was happening in this disease, what could be done better to make treatment better, particularly for people who were disproportionately affected, like my family members. So that was it.
Powerful story. And I wonder if we can now shift to the science that you were intimately involved in at NIH and elsewhere. But it seems to me, in reading through a lot of that work, that, and I'm not going to describe it because I was going to ask you to describe it, but there were some very major kind of leaps in our knowledge and understanding of what was going on with diabetes Certainly at some point we had this sense it was just purely an insulin deficiency problem, learning over time that it was more about hyperinsulinemia, insulin receptor issues. Can you talk a little bit about what you think of as the major kind of milestones in scientific progress in our understanding of diabetes that has come about over the last 30, 40 years and your engagement on the science before we start talking more about the population effects? I'd love to spend a minute talking about the science behind all of this.
Well, listen, we could do this for hours and hours, but I know that that's verboten. But certainly at the time I started, we had this sense that all of insulin, all of diabetes and the hyperglycemia and the downstream metabolic effects were largely the result of just not having enough insulin production. And when you don't have enough insulin production, then of course you suffer the ravages of insulin deficiency. But clearly, there were other things, and we didn't know at the cellular and tissue level what were the differences between the different types of diabetes. So people with type 2 diabetes didn't have ketosis classically, so they didn't have classical insulin deficiency. And then when Roz Yallo, who was my academic grandmother, because she was my mentor's mentor, when Roz Yallo and Salman Burson discovered the radioimmunoassay for insulin, we were better able to measure actual insulin amounts in people. And when that was done, that radioimmunoassay made it possible to draw better correlations between insulin itself and what was happening biologically. Well, it was clear that there were people with full-blown diabetes, type 2 diabetes, who had hyperglycemia, who had other kinds of problems related to the disease. Their insulin levels were not only normal, but in some instances, we would call them supranormal. So insulin deficiency was not their problem. So that meant that their responsiveness to insulin was impaired. And so that opened up the gateways of looking into insulin resistance. What happens when you have lots of insulin, but your cells and tissues aren't responding to it? And so now the work that I was doing on identifying an insulin receptor, this was new territory. And I described it in human tissue. Of course, I had to do that with the help of other people who were doing tissue culture, for example, because I had to have a cellular prototype to do this. We discovered the insulin receptor. We discovered that it was regulatable by a number of factors. You could down-regulate it, cause the amount of insulin receptors to actually decrease as the amount of circulating insulin increased. And this was a kind of a braking, a modulating effect, perhaps. Lots of questions. Eventually, what that led to was the next wave of studies, which was once insulin bound to its receptor, what happened? We described that back in when I was at the NIH as a black box, because we had no clue about what the post-receptor pathways were and mechanisms that accounted for all of the myriad things that insulin did biologically. But those things it became possible to understand that largely as a result of the breakthrough in understanding where you had to start and what were the appropriate systems that needed to be devised in order to be able to answer those questions. And since that time, we've simply uncovered so much about insulin and related factors in the biochemical regulation of basic metabolism.
Up there, because one of the mental models that a lot of people have that you really shatter, I think, is this idea that there is this sort of divide between basic science and clinical practice and thinking about population health. And this work that you're describing, deeply scientific, in the lab, has huge population health implications, doesn't it? And you've brought so much of that learning into the broader work that you have done as a leader in the ADA and elsewhere. I wonder if you wouldn't mind just taking a minute and connecting the dots for all of us. So why is this interesting basic science question about hyperinsulinemia and insulin receptor downregulation or resistance? Why is that a population health issue? And how do you see that as as a segue into a public health framework for thinking about these things?
So one of the best examples that I can probably give you is what happened the year after I was president of the American Diabetes Association. We had been working under the rules that of classifying diabetes, diagnosing diabetes, the rules that had been set by an organization called the National Diabetes Data Group. And they had essentially categorized diabetes as two major forms: insulin-dependent diabetes, IDDM, and non-insulin dependent diabetes, NIDDM. And it framed the approach of everybody in terms of who had what, and therefore what were the appropriate treatments for those persons, and what would be the outcomes based on those treatments. So those define the buckets that you put patients in. Well, it turns out that because of what we were learning about the science, that you couldn't classify people so neatly into insulin dependent or non-insulin dependent, because that was a designation of classification based on how you treated people, when in fact, the treatment that people required was a function of many things: the basic biochemistry that was going on, the duration of their disease, how long they had been on the journey, because even people who had classical type 2 diabetes would eventually run out of the ability to produce insulin, and they would need insulin therapy. Did that make them insulin dependent? No, it was a lot of confusion based on a non-scientific approach to classification. So to make a long story short, what we did, we convened a group, I chaired it, the group for reclassification for diagnosis of and nomenclature of diabetes. And we used the science, and we used epidemiological data in addition to basic science data to completely redefine, one, the threshold at which you could make the diagnosis of diabetes, and two, the nomenclature, that what you had were type 1s and type 2s, and type 1 patients, who used to be called insulin dependent diabetes, you could be 60 years old. Now, in the past, a person who was 60 years old who showed up with hyperglycemia would automatically be designated as non-insulin dependent diabetes. And so they'd start treating them with oral agents, totally inappropriately. So the scientific connection caused us to be able to link the dots in a way that we could do a better job of, one, diagnosis, two, classification, but most importantly, the clinical side, we could do an appropriate decision-making process with respect to treatment and following patients. So I think that's kind of it's a sort of a Cliff Notes version, despite how long the answer seems, but it's a Cliff Notes version of how we've basically gone from basic observations to a more appropriate clinical therapeutic strategies.
One last question on this thread here. And so when you then take one step further out and think about the global population, and it's very interesting because obviously in the last couple of years, the role of infectious diseases has come right back into everybody's mind. But I think we had been on a journey as a globe, as a world public health community, to recognize the issues and importance of what we call non-communicable diseases, which is, of course, unto itself a funny term like NIDDM. What does that mean, non-communicable diseases? But that said, certainly when you take a global perspective, started in places like China, India, across Asia, across the African continent, Latin America, the importance of diabetes as a disease of that's going to cause substantial morbidity and mortality, I think has come into view in the last decade, 15 years. How do you see the world as we kind of hopefully at some point pull out of this pandemic, being able to come back and focus on these incredibly important NCDs? But I would love your perspective, particularly on diabetes, from a global perspective. How big a problem is it? Do you see it as something that we're going to be able to wrap our arms around? What are your thoughts on kind of where we stand globally on this?
Yeah, I'm glad you raised this because too often when we get an emergent crisis, we had this with the flu pandemic of 1918, 1919. We've had this with other emergencies that have affected global populations, but through it all, what we've seen is the relentless growth in the prevalence and the impact of diabetes. So I always, even when I talk to audiences about COVID and about how absolutely important it is that we understand what's happened here, that we understand what the comorbidities are that have driven some of the outcomes that we've seen with COVID, that don't forget that there are still conditions that persist and whose, for example, whose prevalence and whose death rates and whose burdens of morbidity and mortality remain high and get higher when there is an acute addition to them, as we've seen with the COVID pandemic and diabetes. And so if anything, what this does is that it drives us back to the basics in terms of why it's so necessary that the things that we put in place, for example, the testings that we put in place for COVID, well, these same kinds of dynamics need to be in place in many communities writ large, here and elsewhere, for diseases like diabetes. So much undiagnosed diabetes still exists. And so lessons that we learn about diseases that rise to the levels of pandemics that we've seen, these are lessons that we really need to apply to what we call, quote, common diseases like diabetes, but these are common diseases that we have yet to fully and appropriately control and master. And therefore, we continue to see the impact of their burden. So I'm hopeful that we will continue to connect these dots and realize that we can't lose sight of those things that we've considered as, well, they're old diseases and therefore we don't really need to give them the same urgency. We do. And I think that's a lesson that we should not forget.
So I love that. It's really the interplay between quote unquote old diseases and these emerging diseases that become such a problem, don't they? I wonder if you could just maybe spend one more minute on that. I've been thinking a lot about how, obviously all of us have been, but how COVID-19 has played out in our country. One of the things that I always remind people is I say, yes, we're all in this together, but we're not all in this together equally, right? It has affected different communities and different populations very, very differently. How do you think about the fact that this pandemic has affected people of color, people living in lower resource settings so disproportionately badly? And particularly, if you could talk a little bit about it from the perspective of people living with chronic diseases, why we think the pandemic has affected them so much worse, beyond the biological issues of the virus, maybe a bit more virulent in some populations. But if you could just build a little bit more on that, because I think it's something we talk about and we mention in passing, but I don't know that it has gotten the kind of energy and focus that it deserves. And so I'd love your perspective on why you think the pandemic has played out the way it has in our country.
Yeah. So I think that one of the things that this pandemic has done is to explode many truths about disparities and how disparities play out in what happens to people in the face of public health crises, for example. That what we've seen in the numbers, when we've seen that African Americans in this country, particularly in the early phases of this pandemic, African Americans 90% more likely to be infected, 70% more likely to die, and these huge disproportions between percentages of African Americans, and I'm just using African Americans because same thing can be true with Latino populations and other communities of color, but highly disproportionate impact in terms of serious illness, hospitalizations, and deaths in African Americans compared to majority population. And why is that? Well, what we've come to understand is that lots of other factors have come into play. And we've heard people talk about the social determinants of health. When you see people who live in circumstances where they can't socially distance, okay? When you see people who live at levels of socioeconomic status where they don't have private modes of transportation, and so they're forced to take public transportation. They can't because they are in jobs that don't provide for paid time off or work from home. That's really a joke. And they're in jobs that are what we call frontline jobs, jobs that bring them into contact with people. And so when you start adding all of those things in, and on top of that, we're still talking about unmet needs in terms of healthcare access. We're talking about communities where when you give somebody the advice that if this is a medical emergency, call 911 or go see your primary provider. You're talking in many instances to people who have no primary provider. And you're talking to people for whom the thought of engaging the expense of a 911 call is anathema. And so they defer, they delay. And so these are all of the kinds of factors that have made a condition like COVID even that much worse in communities of color that are living under these circumstances. And the final thing is that when you think about comorbidities, who are those populations that bear the burden of excess comorbidities? Obesity. You know, one of the leading comorbidities that's associated with mortality. Diabetes, another one of those comorbidities. And when you start running down the list, the same populations that live under the burden of these socio-environmental conditions that make COVID infection more likely and make serious outcomes more likely, these are the same people who are burdened with the comorbidities that make it possible for this disease to have a more virulent course and therefore a more catastrophic outcome.
Thank you. And that's really helpful as a way to remind ourselves that these things are not randomly distributed. The same communities that have multi-generational households where a lot of workers are essential workers are the same ones that are burdened with a whole host of social factors that lead to more comorbidities. These are not random events that, it just happens to concentrate in certain populations, right? That there's a series of, what I would argue, systemic racist policies of centuries that have landed us to be vulnerable in a way that what we see. Ron Aubert, who's our faculty member, and I think you may know Dr. Aubert, he asks a question. I'm going to go to his question first. He says, Dr. Gavin's clearly a great communicator, could not agree more. Can he speak about the importance of being a good communicator of science, which has been so important and such a challenge during this pandemic? So thoughts, Dr. Gavin?
Yeah, well, thanks, Ron, for the question. One of the biggest challenges that we have, and I'm just going to use the current crisis, the COVID pandemic, as a very vivid case in point. When we hear complete and total nonsense in response to the simple question of why have you not been vaccinated? Or what's your hesitation about vaccination? So I think that our response to that has to lead with science. This is a teachable moment. And however much our emotions may be affected by an answer that we view as complete and total nonsense and politically driven and driven by other factors, the fact is that we need to lead with an explanation of what the science is. For example, I had somebody come to my house, a longtime friend of my wife, and she had not been vaccinated. Her daughter was, and her granddaughter was, but she had not been. Obviously, we made sure that she was masked and that she was socially distanced in our presence, but I had to ask, why weren't you vaccinated? Why haven't you been vaccinated? And she said, I don't want anybody changing my DNA. Well, you know, I saw red. I mean, I had steam literally coming out of my ear. And this is an educated woman. This is a woman who's trained at Juilliard. And I said, why don't we spend a few moments to talk about why this is not the case? And I'm not going to try to make a scientist out of you, but I am going to try to make you understand how messenger RNA-based vaccines work, and assure you that they do not have the capability of changing your DNA. And we started, it was a primer on what messenger RNA was, and how this science had been translated into a vaccine, that this wasn't new, that this technology had been around for other cytomegalovirus, for flu, for Ebola, for other viruses. And so the reason we were able to develop this vaccine so quickly was because the technology was on the shelf. And so with her, it was a process of explaining what was not the case based on science and giving her the Cliff Notes version of what was the case with the science. And this has happened when we talk about, I've heard the Tuskegee experiment. Oh my God, if I hear that one more time, it's going to drive me completely nuts. But again, it's a teachable moment, how you make sure you bring the science to the table first. Now, there may be other things that you want to say, do say that, but lead with an explanation of what the science is that should undergird the basis for our recommendations. The long-term outcome of that was about 2 weeks later, that woman who lived in Tennessee called my wife and said, oh, and by the way, tell your husband that I got the shot. Well, I consider that a big, you know what? Hey, I take them one at a time, and that's how we have to do this. But it is absolutely critical that we become teachers and advisors, making sure that people understand the basic platform of science that forms the opinions that we are sharing, the recommendations that we're making, that you don't have to be a Tony Fauci to do that. You know, not many of us are.
So I'm wondering if we can actually, as you were speaking, Dr. Gavin, I was thinking about the few minutes that we had to speak before this event began, and we were talking about Tony, Dr. Fauci, and his pushback, because he has, of course, been subjected to an immense amount of nonsense, deeply unfair. And he has, in recent times, started pushing back in a more aggressive way. And I will tell you, just being very honest, it makes me a little uncomfortable to watch a scientist do that. Not uncomfortable like I think it's inappropriate, right? I just think it's out of our area of comfort. And I'm wondering if you could talk about your reaction to both, not just the attacks on Tony, and I don't want to spend too much time on that and give it more air than it needs, but his response and what it says to you about how science needs to be communicated in an increasingly hyper-polarized world.
Yeah, I think you're absolutely spot on, because it is a very tough situation when you're speaking. First, you're trying to respond to an absurdity. You're responding to an untruth that is so severely misinformed that the first thing that one has to do is to simply make the declaration that that is patently untrue. But now where do you go now? Because it's usually not in a forum that invites detailed explanations of science. I can tell you what I have tried to do when faced with similar situations. I've tried to lay down a modest platform of the science, that this is not how these things work. And in fact, there are many places that you can go to find out for yourself. And then I start pointing out that this is not unknowable. This is information that you can know. And if you were serious about the truth, and if you were serious about looking out for the best interest of your constituents or for yourself, you would take a minute, take a little time, and go to these sources. Don't just take social media platforms that can be largely misguided and misinformed, but there are credible places that are accessible to you, that I urge you, I challenge you to access. And then if you have questions, why don't you then pose questions that would help widen your understanding, so that you can become now an agent of truth, and an agent of the kind of information that empowers and heals. So I think, Tony's in a much more difficult situation, because he's dealing with people who have an agenda, who are openly antagonistic. But I think that to push back by first declaring that that is absolutely not based on any science from any credible source is the right place to start. And then, to the extent that the opportunity is afforded, put in a little bit of the science that is true. And we're always challenged to try to make it second grade, third grade level, but that's our challenge, and we'll try to do that.
And one of the things I always remind people is there's plenty of disagreement in science. It's not that science is monolithic at all. In fact, that's how science progresses. It's that you have a set of beliefs and ideas, and then you have somebody challenge it. But you challenge it through a methodology. You don't challenge it for the sake of challenging it. I mean, you've described all the ways in which you challenged dogma about how diabetes works, but you did it through a scientific process by saying, no, maybe this is not the right way to think about it. And then you engage in that scientific process to challenge scientific consensus. I think one of the things that people have misunderstood in this pandemic, and I think you've done a really nice job of outlining this, is it's not that you can't challenge the science. Of course, that is the fundamental, but you do it through a process, through data and through inquiry, and not by just acting like it doesn't exist.
Yeah, and make it a teachable moment. If you want to argue with me about whether a messenger RNA-based vaccine is better than a vector, vaccine, you know what? We can talk about that.
Absolutely.
But I want to capture this as a teachable moment, and let's explore both sides of the truth, and then we'll come to some consensus about where we go from here.
Shift gears, and there are a couple of questions also come in, but I want to talk about, you've had so many leadership moments in your career and so many leadership roles. One of them, of course, very importantly, was as the president of the Morehouse School of Medicine. And as I've been thinking a lot about, and a lot of us have been, about what are the things that we need to be doing to increase the leadership, improve the number of leaders in public health and medicine. And I guess I have sort of a couple of related questions for you, and I'm just going to put them all on the table. I'd love to hear your thoughts. One is the very special role that I think historically Black colleges and universities can play. And Morehouse, of course, being kind of among the most prominent of them, but there are quite a few good institutions that are HBCUs. And so how do we invest more in those institutions to kind of grow a bigger pipeline? And second, related, but not exactly, one of the things that's been, bothering me a lot and a lot of us is we have made progress in terms of diversifying our healthcare workforce. But if you look at, for instance, the proportion of physicians who are Black men today and compare it to 30 years ago, there ain't a lot of progress. And again, I always want to think about progress and think about where else we have to go. But this has been an area where I just can't believe we have made as little progress as we have. And so I'm wondering if you could also just sort of talk to that specific issue, but also more broadly about the role of HBCUs in really helping us build out a whole new generation of leaders in medicine and public health.
Yeah, let me just start with the broader question first, because I was involved in some aspects of the 3,000 by 2,000 campaign of the AAMC years ago. It was an ambitious goal of trying to achieve 3,000 matriculants to medical school by the year 2000. And lots of things were done, and that goal, however, was never realized. And over the ensuing years, the next couple of decades, we've seen examples of what you just summarized, namely that despite the population demographics and the way they've shifted, we're seeing fewer, for example, Black males matriculating in medical school. And when you look at representation, that is representation of underrepresented minorities in medical school writ large, based on their percentage growth in the population, we've seen gaps widen, except for the Asians. And so we've clearly missed some important pivot points. And one of those, of course, is the fact that we've kept the standards and the processes required for admission pretty much the same. We've made some modest modifications, but the fact of the matter is that the leakage, the early leakage from the pipeline has never been stemmed. In fact, if anything, it's worsened. And so when you look at the story with Black males, we have not yet gotten our arms around what changes need to be made well in advance of high school to shut off the leakage in those students who would be engaged in STEM programs, who would go on then to be eligible. And so we've got to go back farther than we've gone in terms of setting up programs and policies with some intentionality, because people do lots of things. I mean, I, for example, look at the $100 million commitment that Brown made, 6 years ago. I don't know what the progress has been. I know that that it's certainly been a significant commitment, and other universities have done the same. Emory, where I'm on the board, we've made those. So these are serious gestures, but I think that what's being missed are some of those fundamental changes that are happening that have caused erosion and leakage in the pipelines. We need more pathways types of programs to be shored up. And here's where HBCUs become even more important, because virtually every HBCU that you name or can think of is going to be nested in a minority community. That's where they live. That's where they were born. That's where they've developed and so these become particularly important places for the development of and the implementation of programs that could address some of these same kinds of fundamental questions. But then those become templates for what needs to be done by places that have greater resources and greater capabilities. HBCUs should be test sites, if you will, in many ways, for the kinds of things that need to be done, the target population that needs to be reached, so that you have something now that you can use as a foundation to amplify. And that's why I'm pleased to see, for example, here where I am, this partnership between Emory and the Atlanta University complex. We're seeing more strength in that partnership, because unless we do that, we will never get the kind of coupling that is required. The endowment of most of the HBCUs don't even equal the size of the recent gift that was made to the Rollins School of Public Health at Emory. So resources matter. But then partnerships, in order to make sure that we get on a path that can lead us from where we are to where we need to be, matter perhaps even more.
Powerful. And one just quick reflection is, your point about HBCUs really being embedded in communities where there's a lot more trust and understanding of the institution. We've started a new program at the School of Public Health at Brown where a lot of students from HBCUs were just terrific. And what's been interesting to me in talking to them and spending time with them is the sense, at least some of them, of this question of, would I belong at a place like Brown? Now, from an academic and intellectual point of view, they belong just fine, but that's not the question they're really asking, right? There is a broader issue of, is this a place that's going to be welcoming, and is it going to be a place that, and there, I think the partnership between HBCUs and universities like Brown can be a really helpful bridge to build that. Go back to one of the questions that Nikki W., who's I don't know, a student or a staff or faculty, asked. But go back to your example of to your wife's friend who you sat down with and said, let's talk about mRNA and DNA. One of the advantages you had there was you had a relationship, an existing relationship, and that relationship obviously breeds trust. And so Nikki asks the question, how do you engage with people? I mean, I'm just paraphrasing, who feel betrayed by the medical system, who feel like the medical system hasn't always treated them very well. And this is particularly salient, and you know this better than I do, that particularly salient for communities of color, where, let's be honest, it's not just Tuskegee. Tuskegee is just an example. Yeah. But people will say, and I think rightly so, that my experience yesterday in clinic was such that I'm not sure that I trust the system wholly. In that context, how do we begin to engage people when that trust isn't there, and isn't there for some very good reasons, that, they've been in the way that particularly African Americans have been treated by our healthcare system? Any kind of reflections or thoughts on that? It's a hard question.
Yeah, it's a hard question, but a meaningful question, because it gets to the heart of what gets in the way so often. But I think one of the things that we have to lead with is to acknowledge that the problem exists. Acknowledge that there is this barrier and mistrust, and you don't have to be a genius to figure it out. When you're getting body language, when you're getting response patterns that tell you that, you know what, this is just not clicking, this is not working. Now, this ability that we really have to press for, this ability to deal with uncomfortable truths, becomes crucial. And I think we're at a point where if we don't reckon with this ability to deal with uncomfortable truths, to face the fact that while it may not be your fault that we are here, you are nevertheless part of its legacy. And therefore, in order for us to get from past where we are to a better place, we're going to have to go through some difficult conversations, some difficult situations, and take some chances. It absolutely matters when somebody says, it sounds like you may be having some misgivings here. You may be having a problem with either believing or accepting what I'm saying. Is that something we can talk about? And that cuts both ways. Okay, and if you can have the courage and the forthrightness to do that, sometimes you can create some openings that provide a path forward. But otherwise, what we find is that tension is met with tension. And that is not a formula that is going to lead to a solution for anything when it comes to healing relationships, for example. So it's a tough one, but I think it's part of a broader set of conversations that uncomfortable truths, which is one of the reasons why I absolutely hate to see where we're going with this denial of history. You cannot go forward in a positive way when you don't know how you got here in the first place.
Yeah. I love the idea of acknowledging the history that has brought us here and finding a path through humility of how to move forward, right? It's engagement. I always say, in this conversation we're in kind of more nationally about unvaccinated people, a lot of anger towards unvaccinated. And I feel like anger never moves anybody. I mean, you're not going to bully people into getting this. And that beyond policies, and I do believe in mandates, but beyond that, if you really got to work with people one person at a time, like the way you did with your wife's friend. It is all about hearts and minds, and that doesn't begin with anger. It begins with understanding and humility.
Yeah, and the other thing I would say is that what concerns me is, and why I commented earlier on how you've used a series like this to broaden the perspectives of the people in your bubble. If people never come in contact with folks who think differently, who've had different experiences, and who can articulate why their perspective is different, then there won't ever be a chance for a breakthrough. And that's part of why it's really so important that we have these interactions, albeit uncomfortable. But otherwise, you're only going to talk to people who talk like you, think like you, and you never get beyond that.
Any progress? I'm going to go to another question from one of our audience members who asks about, we're obviously not done with this pandemic, but we're going to have future health crises as well. We're not done with health crises for it. So what are the kinds of questions, investments, strategies we should be thinking about to make sure that we are better prepared, particularly in vulnerable communities, where a combination of longstanding policies, resources, and mistrust create an environment and context in which in the next health crisis can be the same communities and same individuals who are going to be at risk. What do we begin to do now to try to prevent, bolster, strengthen, create more support so we do this a little less badly next time?
This is a question that makes me almost want to shout hallelujah, because I think it cuts right to the heart of where we are. What we've learned, for example, and I'm going to be very concrete, where we've learned in the community where my healthcare organization, Healing Our Village, where we work in Clayton County, 76% African American in that county, 37% vaccinated a few months ago. And, but the testing sites and the sites that were delivering the vaccinations, including pharmacies, that were just not to be found in their communities. So what we had to do was to set up alternative ways of devising an infrastructure based on available entities. There were some schools. There are some schools there. There are some fire departments. There are other entities that, if you use the right creative energy and now take advantage of what you do have and leverage so that you can accomplish the goal. The goal is, if you can't get the people to the help that they need, then you need to get the help that they need to the people where they are. And so we have actually found out that there are some things that can be done that work using available infrastructure, with slight revisions and modifications. These are important lessons, and they are lessons that are to be institutionalized, because we will be here again. And the fact of the matter is, if there's a real indictment that's to be had. It's an indictment that we have not learned from the other episodes in our history of public health crises that we've had in the past. We've not learned from those sufficiently to be prepared for the next one. We certainly find that to be true in the case of COVID. But here now, I think we have had a more rigorous wake-up call. And so we have to really take these lessons and archive them and build them into our infrastructural capabilities so that we know how to leverage, what to leverage, and what resources are going to be required to do it successfully.
So many important points there. One, I'm going to just highlight. It's really obviously investments, new infrastructure is often very important. But one of the points you're making, which I think is so powerful and we forget, is that we don't leverage the infrastructure we have. There are entities, there are organizations, there are capabilities that are quite substantial, but they don't fit into our mental model of where do you deliver vaccines? Because it's always at a CVS or a Walgreens. Actually, it could be at a fire station, right?
Absolutely.
It could be at a school. And if we don't think creatively in those moments, we're fighting the wrong battle. And we've got, and yes, in the long run, we've got other work to do, but in the short run, there's a lot of opportunities. I only have 2 minutes left, and I'm so grateful for all the time you've given us. So I'm going to ask you the question I've been meaning to ask you all hour, which is I've been doing some reading about you and all of your accomplishments. One of the accomplishments that's gotten very little attention, I brought this up just before we got started, I know you know what's coming, is that there was some sort of yo-yoing championship in the background of Dr. James Gavin III. And I don't know, I don't feel like it gets enough attention. Can you confirm or deny that there has been some expertise in yo-yoing, and whether you're bringing that to light now in your life?
Yeah, I grew up with yo-yos as one of our favorite toys, okay? And I developed a bit of expertise. When I was a senior scientific officer with the Howard Hughes, one of my investigators at Salk, Ron Evans, actually challenged me to a yo-yo match. And he was a yo-yo aficionado. And he had no idea that I was ready for him. And he gave me one of his yo-yos, and I wore him out with his own yo-yo. So he gave me a gift of 2 yo-yos after that, but I never had any trouble with him after that. So be careful who you challenge to yo-yoing.
Dr. Gavin, I'm just going to take 30 seconds to not just thank you for taking an hour of your time to spend with us, but for your extraordinary leadership in diabetes, in public health, in building up institutions that are really fundamental to improving public health and medicine in America. As I said, if any of us accomplish a quarter of what you have, we feel very proud of our own careers. You really are a hero to so many of us. And so I want to say thank you. This has been a delight and a pleasure and an honor. Stay well, and thank you again for everything you've done for American medicine and public health.
Thank you. You're very kind. Keep up your great work. I really appreciate it.
Be well, sir. Take care. Bye-bye, everybody. And everybody, thank you for joining us on this really important conversation, and look forward to the next one. I will quickly say, next time it's going to be Dr. Seth Barkley, who's the head of Gavi, the Global Alliance on Vaccines, talking about global vaccinations and WHO and what we're doing. So that's going to be coming up in March. But again, Dr. Gavin, thank you so much.
Bye-bye.